Hey everybody, this presentation is going to cover acid-base disorders. As an overview for the pH scale, going from 0 to 14, our normal range is 7.35 to 7.45, whereas 7.4, that perfect medium, that is the good pH scale for that perfectly healthy person. Their blood has a pH of 7.4. So in our world, how we can apply that to the body is, if you look at the scale here, as there's an increase in CO2, there's also an increase in the concentration of hydrogen, and that decreases that pH scale. So if you think of 0 on the pH scale, that is just 100% acid. That's all it is, just acid. So as that concentration of hydrogen increases, that basically means that acid is just strictly hydrogen. So if the blood is just strictly hydrogen, it's going to have that low pH at 0, but the body's not going to get down that low. It's not survivable even close to being that. So going up towards more of the alkaline side, there's a decrease in CO2 production, or just a decrease in CO2 overall, a decrease in that hydrogen ion concentration, but that increase in the pH. Here's another visual to help try to explain the pH scale. So if you look here at this picture, so all the little red circles and dots, or whatever you want to call them, those are all hydrogen ions. So if you think about the concentration of it, it is mostly all hydrogen ions. So that increase of hydrogen ion concentration means a decrease on the pH scale more towards that acidic side. So with that, that would be an increase in CO2. Overall CO2 is going to make that more acidic. Also, if you look over here, that your baseline is right here, this pH of 7. Okay, that's distilled water, perfect the blood level, perfectly healthy person. Your concentration to of everything else in here, your H and your OH is everything perfect. Okay, so everything a 50-50 ratio pretty much. Okay, so then as it goes up more towards the acidic side, that concentration is relative towards what that pH scale is. So if it's a pH of 6, that's 10 times the concentration of hydrogen. Whereas if it goes up to a pH of 2, that's 100,000 times the amount of hydrogen ions as what is at the pH scale. Then on the other end of the spectrum, you look at your concentration of hydrogen ions. Not much going on there. One little single hydrogen ion. Okay, so as the hydrogen ion concentration decreases, your pH increases more towards that alkalinic scale. And so if you go based off of the neutral, say a pH of 10 is 1/1000th of the rating of what that neutral pH neutral is. So that'd be 1/1000th the time of how many hydrogen ion concentrations in there. So a whole lot less. So then again, just knowing that your CO2 levels all relate into that. So your total CO2 is basically determining your amount of acidity or alkalinity in that blood. As a review for airway pathophys, as the ventilation occurs, which brings oxygen into the alveoli, oxygen comes in, and then diffusion occurs during cellular respiration. Now oxygen hops onto the blood, and the CO2 offloads on it. So ventilation brings the air in, respiration is what causes that gas exchange. Our body measures out the amount of CO2 in there in efforts to compensate and buffer. So right in the ascending aorta is a chemoreceptor. That's not really like this pressure gauge as shown here, but the body does measure the amount of CO2 in there because that's the freshest blood just as it comes out of the lungs. So as that CO2 goes into the aorta, the body's measuring all of that out. So Then that CO2, when it measures out, when that gauge, that chemoreceptor is measuring the amount of CO2, it sends a signal up to the medulla oblongata, telling it how much CO2 is being measuring in there. So continually sending that signal to the medulla oblongata, because that medulla oblongata determines our baseline respiratory drive based on the amount of CO2 in the body, not oxygen, but CO2. That CO2 is the primary driving source for our respiratory rates. So once that medulla oblongata assesses how much CO2 is in there, it either sends a signal down to the sympathetic or the parasympathetic nervous system, putting it into speed up or to slow down. So when it tells it to speed up, that's an effort trying to lower the level of CO2. So as respiratory rates increase, it's going to lower the level of CO2 in the body. And also, when that causes that towards the side of hypocapnia, a reduction in CO2 will also change the diameter of the blood vessels itself. So as respiratory rates increase, CO2 goes down, and also the diameter of the blood vessel goes down. And then just the opposite, as respiratory rates go down, CO2 levels will rise, and as CO2 levels go up, the diameter of those blood vessels will as well. Respiratory acidosis is caused by hypoventilation, and with that there's multiple, or can be multiple, underlying issues that go in that. Whether that was caused by a central nervous system depression, such as the patient who just shot up a bunch of heroin, fentanyl, is on some kind of narcotic, or they're really intoxicated. Something has depressed that central nervous system and slowed their respiratory rate. Lung diseases like chronic ones such as COPD, or more acute issues like pneumonia, their lung tissues are just tired, the muscles are tired, and they're just hypoventilating, and they're not getting in the kind of volume or the oxygenation that they need to. From even other acute things, from bronchospasms such as acute asthma, other things tied into allergies, or bronchitis, acute issues like that, or other means of hypoventilation such as from trauma, like a brain injury, stroke, a flail chest segment, to where they're just not getting in the volume or the drive that they need, or other chronic medical issues such as Parkinson's, muscular dystrophy, where their muscles just don't work as well as they should, and they don't take in that good minute volume as what the body needs to maintain homeostasis. Then on the other end of the spectrum is respiratory alkalosis. That's caused by hyperventilation. Generally, that's secondary to a metabolic issue. Some other things that are more respiratory specific would be like a pulmonary embolism, pulmonary edema, acute hypoxia. Other things that could tie into that would be something more like anxiety attacks or psychiatric issues that are just making them hyperventilate, like that teenage girl whose boyfriend just broke up with her, and she's very excited and breathing really, really fast just because the world is about over. Or some other medical things like encephalopathy, just a brain disorder. Whereas on the metabolic side, such as sepsis, DKA, things like that, that's causing them to hyperventilate, which is going to eventually put them into respiratory alkalosis. And then speaking of that respiratory alkalosis being caused by a metabolic issue, is metabolic acidosis. So the buffering system for that metabolic acidosis would be tachypnea. The body is acidic and it's hyperventilating, creating a tachypnea, trying to blow off that amount of acid, blowing off CO2. So dealing with that, there's basically three components that can go into metabolic acidosis. One is renal impairment, such as a patient in DKA, that diabetic ketoacidosis. And we all know that fruity odor caused by the ketone production, well, those ketones produce hydrogen. So if you get more hydrogen ions, you're going to become more acidic. So DKA produces hydrogen ions, makes the patient very acidic. That's why they hyperventilate and have those small respirations trying to blow off that acidity. Or another cause, production or absorption of acids, such as an overdoses if the patient has taken too much aspirin, or if they've ingested methanol or ethylene glycol, which can be found in antifreezes. Methanol is actually in a lot of like racing fuels, airplane fuels, antifreezes, windshield wiper fluids, things like that. Those crazy things that people can overdose on. And also with those acids is if the body goes into anaerobic metabolism, if they're not getting an adequate amount of oxygen, they're going to go into convert to anaerobic metabolism because there is a decrease in ATP and CO2 production, and they're going to be hypoperfusing. They'll be in shock from hypovolemia, or if there's sepsis or an obstructive shock, etc. And finally, the last one is that loss of a buffering system, such as an end-stage renal disease, where the kidneys and the liver can't filter everything that they need to, and they can become really acidic. Or if there's major lung diseases, because the lungs are used to buffer metabolic issues. So if the lungs are impaired, those two will disrupt that buffering system. Metabolic acidosis is simply anything that causes bicarbonate levels to rise or the hydrogen levels to decrease. So a lot of times that's just going to be caused by volume loss, a loss of potassium, or loss of chloride. So generally the underlying issues with this most generally are extreme vomiting, diarrhea, loss of fluids that way, excessive NG suctioning, so you're suctioning out everything out of the gestational tract that doesn't need to come out, and diuretics that will just make the person volume depleted and chronically dehydrated. The only true diagnosis for metabolic issues comes from doing blood work in the hospital or at the physician's office. Wherever blood work is drawn, that's the true diagnosis to it. In the field, we can do some good detective work and assessments, but the bicarbonate levels in the blood need to be measured to get the true diagnosis of any kind of metabolic issues. The body has a buffering system, and what that means is the body always wants to measure out and evaluate that pH level. Just like if you or anybody you know has a pool, that's always the one thing everybody's the most concerned about, is measuring the level of pH in that pool. So the body's doing the same thing to maintain that homeostasis, just like the image shows, that fine balancing act, not teeter-totter. The body needs to buffer itself out to keep that appropriate level on that pH scale. So the two functioning systems within the body that do that to buffer is the lungs and the kidneys. The kidneys work to create that buffer in the metabolic system, and the lungs, well, of course, they are that buffer for the respiratory system. So before we talked about in those metabolic issues, those increase in bicarbonate issues, that's what the kidneys are doing. They are buffering out using bicarbonate, whereas the lungs buffer using balancing out the levels of CO2. So CO2 and this bicarbonate go hand in hand when it comes to balancing out the pH system. So you got your big three components of pH, and then you've got your bicarbonate, and then you've got your carbon dioxide. Those three things go hand in hand of balancing out homeostasis within the body. So as you look at this slide, don't get freaked out just yet. So this just kind of explains and goes in a little bit of detail of how all this works. So at the top here, if you look at the second line, glucose and oxygen create CO2, carbon dioxide, water, and energy. So that should seem familiar to you. That's Krebs cycle. Oxygen and glucose equal CO2, water, and they produce ATP. That is aerobic metabolism, essentially. So thinking back all the way back to chemistry days, if you really break all this down, the top section up here, this is the chemical equation of how all this really goes and breaks down. Okay, and as we all know the water boy, how much he loves water. Well, CO2 really loves water too. So if you're looking down here, CO2 and H2O bind. Once they're produced from that aerobic metabolism, they can reversely form bicarbonate and a separate hydrogen ion and carbonic acid. So all this can be broke down. Your H2CO3 can be broken down into a separate hydrogen ion and that carbonic acid. So that's just your CO2 and water, your bicarbonate, and then your hydrogen and carbonic acid. Ooh, scratch out the word. But all those can go back and forth together. So the big things you just need to focus on is that CO2 and bicarbonate go hand in hand. As you see in here, as your CO2 increases, basically your bicarbonate is going to increase. And then with water, we can easily excrete out all three of these. Okay, so these are good to know, but right now we don't need to focus on this part. So we'll just scratch all that out. So just remember that CO2 goes hand in hand. The more CO2 that's produced, the more bicarbonate that's produced. And so we balance out the CO2 by breathing, and we balance out the bicarbonate by peeing that out. That's where your renal system comes in of filtering all that out, and we can excrete that bicarbonate and that water out just by peeing. As I said before, the buffering system and balancing that pH scale is just a fine teeter-totter to balance out, maintain homeostasis. So if you see in the interpretation here, as that pH will slowly start to shift and go down towards that more alkalytic side. So if in an event it's doing that, if that pH scale is starting to shift towards the alkalytic side, that more basic side, if that's an instance of metabolic acidosis, that means there's a decrease in bicarbonate. So in that decrease in bicarbonate, it's alkalytic, so the body needs to become more acidic. So what the body does to buffer that is try to implement respiratory acidosis to compensate. So knowing that that pH is going towards the alkalytic side, the body's going to depress that respiratory rate a little bit to try to increase the amount of CO2 to buffer out that bicarbonate to get the pH back towards that neutral 7.4 perfect homeostasis. Now in the event that if that is respiratory alkalosis, which is caused by that increased respiratory rate and a decrease in CO2, the opposite's going to happen. The body's going to compensate by trying to create metabolic acidosis by retaining that bicarbonate. So the kidneys aren't going to filter that out and not let the body pee it out. It's going to keep it in the circulating system. So it's not going to filter it out, just let it stay in that blood, flow on through to try to balance out that pH. And on the other end of the spectrum, if the body's shifting down towards that acidotic side, so if in metabolic acidosis, there's an increase in that bicarbonate. So if there's a metabolic acidosis, the body's going to try to start compensating by creating respiratory alkalosis. So that respiratory alkalosis is caused by that increased respiratory rate, which is going to lower those levels of CO2. So as the bicarbonate goes up, it's going to try to decrease the CO2 production because CO2 and bicarbonate go hand in hand. So if it's lowering that CO2, it's also going to hinder the production of bicarbonate, inversely lowering that bicarbonate. So if it's respiratory acidosis, which is caused by that decreased respiratory rate and increased CO2, the body's going to buffer by going to metabolic alkalosis to try to compensate for that respiratory acidosis. So it's going to get rid of the bicarbonate ions by excreting them out, meaning essentially the kidney's going to start filtering it out heavily to try to lower that amount of CO2. Since that bicarbonate and CO2 go hand in hand, the body's going to start peeing it out to try to get it lowered out. Even though the body's going to be buffering and try to balance out itself, it can only do that for so long. It can only compensate. So just like that shock patient, it can only compensate by increasing that heart rate and causing vasoconstriction for so long, trying to keep itself alive. So that's where the interventions come in through assessments and monitoring. So in terms of respiratory acidosis and alkalosis, the big thing is just to treat those underlying issues or the underlying cause. So if they're hypoxic or they're hypoventilating, give them oxygen, ventilate them. If they've got an inadequate airway, create a patent airway, suction them out. If they're having ventilation and airway issues, give them those beta-2 agonists, open up their bronchioles, let that diffusion and gas exchange occur again, or bring back that respiratory drive by giving them naloxone. If they're to the point where they're hyperventilating, it's a psychiatric issue. It may just be simple as just calming them down, trying to get them relaxed, or it could mean complete sedation of that patient so you can take over the respiratory drive. In terms of metabolic acidosis, that's going to be indicated by an increased respiratory rate and low end-tidal CO2. Now there will be times in this where you need to just let the body do its exaggerated motion, such as in diabetic ketoacidosis. So if they have those Kussmaul respirations and they're breathing 30-40 times a minute, just let them breathe that fast. If you slow down that breathing, that's going to increase the cascade and increase that level of acidosis. They're breathing fast, trying to get rid of all that acid. So if applicable, just let that body compensate in such instances as DKA. Also, in some metabolic issues, you might see ECG changes to help you do a differential diagnosis of really what's going on. So you might see those widened QRS complexes, or you might see peak T waves. So a lot of times, one of the most common things we might see from that is that patient who has doesn't have a buffering system because they're an end-stage renal disease, so they're going to dialysis and they've missed dialysis. So that's one of those big things we always look for in those patients being dialyzed, is that hyperkalemia from that peak T with those peak T waves. So if you see any ECG changes, that might be a time when you could go and intervene to give them an alkalytic medication such as sodium bicarbonate. But most of the time, before any bicarb is given to general metabolic disorders, blood work and everything needs to be done beforehand. Otherwise, everything you can find in there, treat the underlying issue with these patients. With metabolic alkalosis, some things that you may discover in the patient's history would be the patient might be on antacids, and those antacids are full of sodium and calcium bicarb, hence they're an antacid. They try to make you less acidic. So to be less acidic would make you more alkalotic. So if they're taking too much of that on top of any kind of underlying issue, it's going to make them extremely alkalotic. Or patient might be on a diuretic. So diuretics are known to cause volume depletion, causing all that fluid to be shifting. So a lot of times these metabolic patients are in need of a lot of fluid resuscitation. So you're just again going to treat any kind of underlying issue and everything you can find, because with metabolic disorders, that's a blood work discovery. So if they're volume depleted, give them some fluid boluses. And metabolic disorders, isotonic crystalloids like sodium chloride are the preferred choice of fluids for these metabolic disorders. Since we're talking so much about CO2, I'm sure a lot of people are thinking about measurements of that CO2 with use of end-tidal CO2 and capnography. So that is generally a direct correlation. They're generally within really close to one another. There was a study many years, or not many years ago, but a few years ago, of a whole bunch of respiratory patients, and what their end-tidal CO2 said was within about 2 to 5 millimeters of mercury of what their ABG actually showed. So a really good correlation, as long as there is not a VQ mismatch. And VQ mismatch means there's a discorrelation between ventilation and perfusion. So there's a ventilation perfusion mismatch. So one place you might see that is if you have you're doing waveform capnography and you see a low end tidal CO2, but there's not an increased respiratory rate. Because you know, if you increase your respiratory rate, you're going to blow off CO2. So there is a VQ mismatch there. So basically your two instances, or the two things that are going to cause that is there's a lung being ventilated that's not being perfused. So that there's air getting into that alveoli, but there's no blood getting to it to circulate all that through and to bring the CO2 back. Okay, or the opposite, you've got a lung that's getting perfused, but it's being hypoventilated. So that would be something like atelectasis or a COPD bronchoconstriction patient. Okay, so the big thing is if you see that VQ mismatch, to fix what's on one side or the other. Okay, so if that patient is believed to be hypoperfused by, you know, weak pulses, cool, clammy skin, improve that perfusion, give them some fluid or some pressors. If they have good perfusion statuses, good heart rates, good blood pressures, you don't see any signs and symptoms of hypoperfusion or shock, improve that ventilation, give them some oxygen, give them some volume of CPAP, give them a bronchodilator to open that up. You know, give them that CPAP if it's atelectasis to create that PEEP pressure to open those alveoli back up. Give them a beta-2 agonist to get those bronchioles open back up. Give them some oxygen. Get rid of that VQ mismatch. So fix the ventilation or fix that perfusion. Because on mostly all of our patients, if they've got a normal respiratory rate, we should be seeing at 35 to 45 in tidal CO2 range. If not, something's crazy, especially on that low end. So the low end is a VQ mismatch. On the high end, that's gonna be your respiratory patients who are retaining a bunch of CO2. So again, if you see low CO2 without hyperventilation, there's a VQ mismatch. Fix the perfusion, fix the ventilation. So with that said, that's a really good assessment tool if you do see the VQ mismatch to be assessing those airway issues or hypovolemia, sepsis, that patient with low end tidal CO2, tachycardia and a fever, that's a septic patient. Or that patient who's mildly hypotensive but not hyperventilating who has a low end tidal CO2. They're in the first stages of shock. Fix their volume. Fix the volume with the sepsis patients. Give them some fluid. If they're a COPDer and you see they got a low end tidal CO2, but they seem to be oxygenating okay, go ahead and give them something to open them up. Get something in there, get that gas exchange going again. Let's do a quick review. So that pH scale, the normal pH is 7.35 to 7.45. So we've talked a lot about how CO2 relates to the pH scale. And our normal end tidal CO2 is 35 to 45. So they're again reinforcing why CO2 relates so much to pH. So on the acidic side of things, that respiratory rate goes down, which causes CO2 to go up. So CO2 increases, so does that concentration of hydrogen ions, which reduces your pH. So if you can also think about what would cause your respiratory rate to go down is going to cause your pH to go down. CO2 goes up, hydrogen ion concentration goes up. Same holds true on the basic side, the more alkalinic side. Respiratory rates increase, which causes CO2 to decrease. So that respiratory rate goes up, so does the pH. As CO2 goes down, so does your hydrogen ion concentration. And just remember that hydrogen ion concentration and the pH itself are inversely related. So pH goes down, hydrogen ion concentration goes up. pH goes up, hydrogen ion concentration is lower. So using those tools and remembering how to balance out that CO2 is going to help balance out their pH. Okay, so remember that if there is times that VQ mismatch. You need to be thinking about that. Are they properly ventilating? Are they properly perfusing to make this end tidal CO2 correct? If you're seeing high levels of CO2, you know what you got to do to get them down. You've got to get them ventilating better, whether you ventilate them yourself or you open them up with some medications. If you see that CO2 increasing or respiratory down, you know how you're going to have to manage these patients. So using that end tidal CO2, using that capnography is going to help you greatly. But still remember those diagnoses in your head of, hey, this patient that they're hyperventilating and their glucometer says high. Yes, sometimes you need to just let their buffering system take itself. So just remember when you're identifying these things that sometimes these abnormal things you're finding are part of the buffering system, and sometimes they just need to go. So a lot of times with it, it's supportive care, and it's going to need long-term care in the emergency or hospital setting. Thanks for watching.